right, I'm going to go ahead and get started here. We wanted to start the talk by asking a question. Have you ever been a single coverage doctor at a standalone or just at the Solar Hospital where you have a pediatric patient walk in with a distal radial fracture and you're unable to do a procedural sedation? This could be a painful pediatric problem and a problem that we found ourselves in. Today, we would like to go over 5 peripheral nerve blocks that could save your butt. I'm Dr. Jennifer Purcell, and this is Dr. Sanaho Gajal, and we're from Grand Strand Medical Center, and we're their ultrasound fellows. Some objectives that we wanted to go over was understanding the basic principles of performing a nerve block, delineating the difference between performing a nerve block for a pediatric patient versus adults, and describing the indication of the 5 nerve blocks that we picked out, recognizing and managing potential complications as well. Just wanted to take a few seconds to introduce our team up here. This is Dr. Casey Wilson. She's our Emergency Medicine Program Director and also our Ultrasound Fellowship Director. Dr. Pope is our Assistant Ultrasound Director, and Dr. Richardson is our Ultrasound Faculty and also our POCUS Liaison. We have no conflicts of interest. Here's just a little bit of background about our facility. Grand Strand Medical Center is at the heart of Myrtle Beach, South Carolina. There you go. We are the second busiest travel destination in the United States, right behind Orlando, with approximately 125,000 visits per year. We're also the busiest level 1 trauma center in the state of South Carolina. We're a level 2 pediatric trauma center, and our volumes for peds tend to increase during the summer months about 30%. We're also the regional referral center for stroke and STEMIs. So why is this topic important and why is it relevant to us? It's no secret that nerve blocks have been gaining popularity and traction with the increase of ultrasound use within residencies. Just about a year ago, ACEP released this policy statement about ultrasound-guided nerve blocks utilization in the emergency room practice. Pain is one of the most frequent complaints that we get in the emergency room, and we have multiple modalities to control pain, but often they fail or they cause adverse reactions that we don't want. Ultrasound-guided nerve blocks have been proven to have a safe and effective modality for pain control. They have also been associated to improve post-surgical outcomes, decrease delirium, and decrease length of stay without any increase of adverse effects. We all know that nerve blocks are great for the adult population, but do we really think that we're ready to bring it to our pediatric population? We would argue yes. There are many wonderful uses for nerve blocks for the pediatric population, and we want to spend the next 20 minutes convincing you and showing examples how we have applied it to our shop in the last 6 months. These cases are examples where we have successfully avoided using procedural sedation, and we were adequately able to treat acute injuries by using a nerve block. We also made the staff and the family members extremely happy. So here's some indications for nerve blocks for children are largely the same as adults. However, there are some special considerations that you'll want to take into account. It is more critical, we feel, to have a 2-person verification system for the toxic dosing of local anesthetic due to the volume of distribution. You also need to consider that the metabolism of anesthetics in children is often delayed. There is also no high-level evidence available to guide dosing for local anesthetic uses in children. However, the American Society of Regional Anesthesia and the European Society have given us some recommendation and guidelines, and we put a link to that on your handout. It's a lot of information, and we didn't want to fit it all on the slide, so you can refer to the handout for that link. So as you can imagine, as we've incorporated this into our practice with peds, we've had to come up with some tips and tricks along the way, and we want to take some time to share those with you. I love applying EMLA to the area where I'm going to do the nerve block to just apply some local anesthetic before actually puncturing with the needle. Another, if we're at the main hospital, is using a child life specialist, also allowing the child to play with the gel or using distraction techniques like a tablet, playing with bubbles, just getting them more familiar with the machine before actually doing the procedure. One of our personal favorites is doing the probe selfie, or just letting them play around a little bit before you actually get down to doing the nerve block. Always have appropriate consideration and patient discussion for risks and benefits of the block should always be performed prior to doing the nerve block. Block placement should not delay any other time-sensitive interventions. Use a probe cover, don't be gross. Use appropriate splinting, protection, icing of the extremity. And a thorough, detailed compartment exam should always be confirmed, as well as a neurovascular exam. You should always document that you did the nerve block in your note. And we like to use templates from Highland Ultrasound. They have fabulous templates if you don't have any templates for nerve blocks. We also have a link of that in our handouts as well. When you're doing the nerve block, you always want to have real-time ultrasound guidance and have the patient on the monitor. While you're injecting, don't forget to aspirate. You also want to have interlipid on hand in case there's any toxic side effects, and have appropriate post-block care. What I like to do is either to get a big Band-Aid, put my initial on it, and time and date it, write what anesthetic I used and the concentration and volume as well, and then place it where I did the nerve block, so there's no confusion that a nerve block was done. So this is just some equipment that we have in Grand Strand. We use sterile gloves, ChloraPrep, bupivacaine. We have nerve block needles. If you don't have nerve block needles, you can also use a blunt tip needle as well, just applying it to the end of the syringe, and then probe cover and sterile gel as well. I like to use the blue towels too, just to create a sterile field. You don't have to do this. It's an aseptic technique, but I just feel that it makes everything a little cleaner. So we're gonna get into cases now, but it's a lot of information that I realize that we're throwing at you, but we just wanted to go over an overview so that we're also able to break out into our group sessions.
Now we're gonna highlight some examples of how you guys can apply this in your clinical practice. Our first case, we have a 10-year-old male who presents to the ER via EMS with wrist pain after falling off of his skateboard. These are his wrist x-rays. An incredibly common injury, however, if you guys don't have access to a pediatric orthopedic surgeon or orthopedic residents immediately available, this is kind of the bread and butter of an emergency physician to manage. What's your approach gonna be? Do you guys wanna place an IV, use ketamine, intranasal Versed, or do you wanna use a longer lasting analgesic option that can bridge you to oral medications that your patient can go home on? Our first block is a variation of the brachial plexus block, the retroclavicular approach to the infraclavicular region. Most people just like to call it the Raptor block. The Raptor's claim to fame is that it's a modification of the infraclavicular block, and it allows you to approach your target at a less steep angle. This blocks motor and sensory that's distal to the shoulder, and it's considered safer than your inner scalene blocks because there's decreased risk of diaphragm paralysis. Landmarks are usually easily seen on ultrasound, and most patients tend to get relief within about 5 minutes of the block. The other good thing about this block is that there's minimal discomfort, and your patient can lay flat in a comfortable position when you're doing the block. The Raptor is great for supracondylar fractures, humeral fractures, distal radius and ulnar fractures, and you can also use it for shoulder dislocations and elbow dislocations. For any of you guys that have done fracture reductions in the past, you know that your first attempt's not always satisfactory. So the benefit of a nerve block is that it provides a prolonged duration of anesthesia to allow for repeated reductions if necessary, and it avoids repeat bouts of sedation. So to perform this block, you're gonna have your patient laying supine. Their affected extremity is gonna be adducted to their side in a position of comfort. Something else you might wanna consider is placing a roll or a pillow behind their affected upper back, and that just opens up that supraclavicular area where you're gonna be placing your needle. You're gonna be standing at the head of the bed, and you're gonna have your patient rotate their head away from the injured extremity. You're gonna be using a linear probe for this. Your probe marker is gonna be pointing cephalad. You're gonna start at the medial clavicle and then scan laterally until you reach the deltopectoral groove. At this point, you're going to rotate your probe slightly to point towards the axilla. What you should see at this point is that the axillary artery is going to emerge from underneath the clavicle. To perform the block, you're going to place your needle about 2 centimeters above the clavicle. Just keep in mind that if you do have a larger patient, you might want to start a little bit closer so that you don't run out of needle. This is going to be an in-plane approach where you lose sight of your needle as it goes underneath the clavicle, and then you'll approach your posterior, medial, and lateral cords that are located around the axillary artery. Keep in mind you want to keep your angle parallel to the bed and then aspirate before you inject. This is a still image of what you should see on the ultrasound. The medial, posterior, and lateral cords flank the axillary artery like the hands on a clock. And while this is not always sonographically echogenic, knowing your anatomy can kind of help you locate where they are. Again, it's the 3 o'clock, 6 o'clock, and 9 o'clock positions around the axillary artery. This is a live image of us performing the block on our 10-year-old patient. You guys can see needle coming in and kind of targeting the posterior cord here, and then needle depositing anesthetic around the lateral cord, and this will spread around your axillary artery. I can repeat that for you so you can look at it again.
So case 2, we have a 5-year-old male presenting to the ED with a fishhook in his hand after playing on the beach. So we decided to do forearm blocks, the ulnar nerve, the radial nerve, and the median nerve blocks. These blocks are great for foreign bodies in the hand, if you have fractures or lacerations, and if you have a large abscess that needs an IND of the hand as well. There are some limitations to this block. They don't provide anesthesia to the volar, forearm, or wrist. This means that the forearm block will not provide or provides incomplete anesthesia to the distal radius or other wrist fractures. To perform these blocks, you'll need a linear transducer, and you'll go to the mid-forearm in the transverse orientation. The ulnar nerve runs adjacent to the ulnar aspect of its artery, and it separates in the mid to proximal portion of the forearm. The median nerve typically has a honeycomb appearance, and it's in the mid-forearm, and it is in between the flexor digitorum superficialis and the flexor digitorum profundus. The radial nerve is the superficial branch, and it runs laterally adjacent to its artery, and it's sometimes difficult to locate in patients, so we'll go over some tips for that. You'll typically inject 2 to 5 mLs around each nerve. NYSORA recommends that you do 0.1 to 0.3 cc's per kg for the pediatric population, and images that are shown up here are just the sensory distribution that we have of the nerves. So first up, we have the ulnar nerve block. This is an example of how you would position your patient and perform the block. You'll have the patient have their hand facing the ceiling, turn their thumb a little bit towards the bed to open up the ulnar aspect of the forearm, and then you'll start looking for the ulnar nerve in the mid portion of the forearm, and you'll see that the nerve is on the same fascial plane as the artery. So here we have the ulna bone, and then right above the ulnar nerve, an ulnar artery, and this is the fascial plane that you'll be looking for as well. For the radial nerve, you'll start at the mid-radial aspect, also palm facing up. This time you'll have the pinky roll towards the bed or towards the table, and what you'll see is the cortex of the radius with its shadowing, and then the nerve and radial aspect of the radial artery you can see. If you're having difficulty with this, because sometimes this nerve is superficial and small, you can start more cephalad and go to the supracondylar region and then locate it up there and slowly go down the arm. You'll see the radius, and then the fascial plane, the radial nerve, and then the radial artery right there. This also has the median nerve in this picture as well. So last but not least is the median nerve. You'll start at your mid-forearm in the transverse plane. The median nerve will be the only hyperechoic structure that you'll see. and it will be in between the flexor digitorum superficialis muscle right here and the flexor digitorum profundus. And it has this honeycomb appearance, and it really pops out on the ultrasound. Here is just a live in-plane median nerve block that we performed. And as you can see, the needle is coming in right here and then depositing the anesthetic around the nerve right now.
Our next block is going to be the fascia iliaca block. This block is great for hip fractures, femur fractures, patellar fractures, large thigh lacerations. This is going to be the surface anatomy that you'll need to know. Here's your ASIS, tubic pubricle, and this dotted line is the inguinal ligament. Your femoral nerve is going to be the most lateral structure. This picture is showing the suprainguinal approach. There is an infrainguinal approach. However, studies have shown that the suprainguinal tends to provide better analgesia. And for time's sake, we're just going to be going over this one approach. This is the ultrasound still of what your target area should look like. The target for this block is to get underneath the fascia iliaca, represented by yellow here. You are a little bit farther away from your femoral artery, nerve, and vein, so you won't see this on ultrasound with this approach. So again, you're going to be looking for your sartorius highlighted in red, your internal oblique highlighted in blue, and what this is called is the bow tie, so it should resemble a bow tie. It's made up of the fascia iliaca covering underneath the internal oblique and the sartorius, and the fascia lata that sits on top of these two muscles. You'll also want to look for the iliacus muscle, which wraps around a hyperechoic AIIS. You also want to be aware of a small artery here, the deep circumflex iliac artery. However, this is often avoided when you enter caudad through the sartorius. You know that you're in the right location when you get underneath the fascia iliaca, and when you deposit your anesthetic, the iliacus peels away from the fascia iliaca. So this is an image that we have of a patient that we did. Again, like we talked about, there's your bow tie made up of the fascia lata on top in green, your fascia iliaca in yellow, your sartorius, and your internal oblique. And you guys can see needle coming in, and as anesthetic is being deposited, the iliacus muscle kind of peels away.
Case 4, we have a 15-year-old male that presents to the ED with an ankle injury after coming from the trampoline park. So we did the popliteal sciatic block, or also known as the POP block. POP blocks are great for distal tibia fibula fractures and dislocations, as well as Achilles tendon lacerations and calcaneal fractures. This is the surface anatomy for the POP block. The distal sciatic nerve is usually found right above the popliteal fossa, right here. Often you can identify it and start in the popliteal fossa. You identify the tibial nerve, and then the common perennial nerve will come in to form the distal sciatic nerve. This block provides great analgesia to the lateral and posterior aspect of the foot. However, it does miss the medial portion, which is supplied by the saphenous nerve. Usually it just misses the skin innervation, but it does cover the bone. These are some still images at the bifurcation. And at the bifurcation, you'll see the tibial nerve and the common perennial nerve. As you slide more cephalad with your probe, you will see the distal sciatic nerve. There are two different ways to perform this block. You can either perform it at the distal sciatic nerve, or you can perform it at the bifurcation with the tibial nerve and the common perennial nerve. Here we have an image with the ankle fracture, and this block was done at the distal sciatic nerve. I like doing it at the distal sciatic nerve because you have one target, it's large, and I just think it's easier to see. You can do it at the bifurcation as well. This is a picture, this is your tibial nerve right here, common perennial nerve, needle coming in. The only thing with this is sometimes you do have to adjust your needle to make sure that the anesthetic gets around both nerves. And back to our ED patient. So this was somebody that we had at a freestanding ER, and we were unable to do conscious sedation, so we were able to do the POP block. We perform the reduction, and we also save them a trip to going to the main ED, as well as providing them pain control.
On to our last case, we have a 10-year-old male who presents to the ER with a laceration on the bottom of his foot after stepping on some glass. Our next block is going to be the posterior tibial nerve block. This block is great for foot lacerations. As you guys know, it can be pretty difficult to completely anesthetize the bottom of the foot, especially because it's so sensitive. A lot of times with these larger lacerations, you'll have to use multiple needle sticks to completely get good anesthesia, and when you're dealing with a kid, you want to minimize the amount of times that you're going to be sticking them. You can also use this block for abscesses and foreign bodies at the bottom of the foot. These are your landmarks and the surface anatomy that you should know: your medial malleolus, your tibial artery, and then the posterior tibial nerve. This block, like we talked about, provides great anesthesia to the bottom of the foot. It is important to note that it does miss a small lateral portion innervated by the sural and a small medial portion innervated by the saphenous nerve. To perform this block, you want to have easy access to the medial malleolus. What this means is that you'll want to place a pillow or a rolled sheet underneath the patient's ankle and have them externally rotate. You can also have them lay on their side and hang the opposite foot off of the bed. What you'll want to do is visualize medial malleolus with your ultrasound, and you're going to slide cephalad until you see the posterior tibial artery and nerve. This is an ultrasound still of what you'll want to see. Here's your medial malleolus with posterior shadowing, and then here's your nerve. Right next to that will be your posterior tibial artery and vein. This is an ultrasound image of a patient that we had. This is your nerve, and this is an out-of-plane approach. You can perform this block in plane, however, with peds, it's a little bit harder to avoid the Achilles tendon since you have such small real estate there, and so performing it out of plane makes it a little bit easier to avoid the Achilles tendon. So in summary, we're committed to improving our clinical practice and promoting compassionate care in all of our patients, especially our pediatric patients who require special considerations when it comes to acute pain management. If we haven't sold you on this and you're skeptical about whether or not this is a skill you can incorporate into your practice, we want to be completely transparent. A lot of our comfort and familiarity came with repeated practice. We started by scanning each other and becoming familiar with the anatomy before using this on peds, and then once pediatric patients came in, we were able to be more comfortable when we knew that they needed a nerve block. As Dr. Purcell mentioned, I know this is a lot of information really quickly, but we wanted to provide you guys with some time to scan as well. So we're going to be breaking out into some small group sessions. Feel free to ask questions once you get to your sessions, and you guys can rotate through.
So we're going to spread, Thank you. So we're going to spread out around the room, and we're going to have our fascia iliaca block over here, our popliteal sciatic block here, forearm blocks in the middle, posterior tibial nerve in the back right, and raptor block back left. And we have the next half hour that you can all just kind of rotate through stations, ask questions, and have a chance to scan each other or our amazing resident models.